right, so we want to take a little different track at the moment, and I just want to start the screen sharing, but I don't know how. So this will take about 15 minutes, and then, I mean, you can, probably we're not going to share too much of the screen here, so let's just go here. So this was something that I did for ESG, and that's why it's in ESG colors, but I think it's interesting from the point of view of stuff we haven't really covered here. So theory, right? So we've covered a load of practical, but much theory is required for colonoscopy, and it's not in there. So most of this is about maximizing your visualization, because I think let's be honest, all this technique is to get to the end. And then there is the whole business of colonoscopy starts, right? So when you start at 50 colonoscopy, your entire focus is getting to the end. But actually, the protective effects of colonoscopy on cancer starts when you get to the cecum. And that's always very, very difficult when you're starting training. I want to discuss with you some missed things and what we're looking for, discuss technical maneuvers you can do on withdrawal, right? Not on insertion, because this whole course has been focused on insertion. And discuss add-ons which you can put on the scope to help you, and discuss artificial intelligence. All of these things are important things. You can come back to this later. You will get loads more of this in your training in here. Maria Ava, you will get a load in the near future, you guys, when you come here. But it's just to give you the ideas, because I think there is something about showing you a whole load of what's possible, and then let you step by step discover it for yourselves. So colonoscopy is all about preventing cancer, and that is by detecting polyps, right? That much is clear. We need to know some definitions for that. What is the definition of adenoma detection rate? Not you. I think you know. What about one of you two? Delphine or Julie?
I don't know what's your detection rate colonoscopy per.
So if I detect, so say that I'm a colonoscopist and there's another colonoscopist, right? So two people, and we do all the same procedure, but in the procedures, one of them detects a load more polyps than the other one. And in the colonoscopies, every time one detects a polyp, the other one detects at least one polyp. Are the adenoma detection rates different? So it's cancer after colonoscopy. So you say to a patient, you've got, in Belgium, 7 to 9% risk of having a cancer within 3 years of having a colonoscopy. And they look at you and they say, how is that possible? How is it possible? You're telling me you're doing a colonoscopy to stop me getting cancer, and I still got a 9% risk of having a cancer within 3 years? But that is the data in Belgium right now. So why is that? Because we're not detecting adenomas. And why are we not detecting adenomas? Well, that's the whole point of the talk. So endoscopist ADR versus cancer risk. And this is so you heard Roland talk about the Corley study in the New England Journal of Medicine, right? He said that. This is that study. And it shows that for every 1% increase in the adenoma detection rate of the endoscopist, you get a 3% decrease in the rate of post-colonoscopy colorectal cancer in the patients who had a colonoscopy by that endoscopist. So that is a huge, huge thing. That's why it got published in the New England Journal of Medicine 2014. And the follow-up study clearly shows that that is still the case in that data set that they're following up. And not only that, but we also know that if you improve your adenoma detection rate, then you can improve your risk, and it's not your risk, the risk of your patients getting cancer after colonoscopy. So, okay, we know ADR is important. I've just shown you a whole load of data to suggest it's important. It's not perfect, but it's important. Well, I think it falls into these categories. If you don't know what a polyp looks like, you're not going to find a polyp. So my own experience, I went to Sydney. I started seeing these things. I was 3 years into my training. I started seeing these things called serrated polyps. I had done 300 colonoscopies at that point. So evidence suggests that I probably should have seen one in 7% of those 300. Let's say that's about 26 colonoscopies in which I missed a serrated polyp because I didn't know what it looked like. So that is one part of it. And it's not just polyps and what they look like. It's also cancer in polyps. So pretty much nobody understands very well how to assess a polyp for cancer risk. It's looking at the patient in front of you and saying, what is the chance of a polyp here? So it's very different for the patient who has, got a bit of abdominal pain and is 25 years old. The chance of having a polyp there is totally different to the patient with PR, loads of blood loss, rectal blood loss, who's 75 years old and who's got weight loss and who's got a CT scan with a lesion in the liver. Now, I'm making it very like this, but of course and if the patient's got a stool test that's positive, the risk is higher, so you should look harder. Men get more polyps than women, so statistically speaking. Intubation, if you get to the end faster, you got more time to look for polyps, right? So that you can do intubation and that you can get there in a painless manner is great for patients, and it's also great for polyp detection. So in general, it's great because no one can change time. No one can change the amount of patients you will have on a program. And therefore, what can you do to optimize your amount of time spent looking for polyps? Decrease the insertion time. And that is possible by listening to the tips that you find in this course and make it painless, because the worst thing possible, and the reason why patients will not get to the cecum in some of your cases without propofol, which I'm sure you will all end up doing in your life, is because patients got pain and you have to stop the procedure. And withdrawal, you need to maximize visualization. And you can break down maximizing visualization much more. And this is just to give you an idea. What is the evidence that high quality colonoscopy is important? What is the hazard ratio of not reaching the cecum and documenting it? 1.8%. What is the hazard ratio of having poor bowel preparation? 2.09%. So if people don't say they've got to the cecum, the chance of having a problem post-colonoscopy colorectal cancer is 2 times higher. So is it if there is poor bowel preparation. And Roland's done a load of work looking at what the actual risk factors are for post-colonoscopy colorectal cancer. They are those 2, and they are also patients with IBD, because they get cancer later. It's very hard to detect it. And having a polyp, a big polyp, when the patient has to come back for surveillance, we know if you have a big polyp, you've got a more chance of having other problems. So get your bowel preparation right, work with your thing. Maybe you can take a pill to highlight polyps. There's a really nice study